Well, that about does it for the microcytic anemias. In case you missed it, we traveled to the land of thalassemias before getting lost in a forest of iron deficiency and chronic disease. Well, it's time to get back on track with normocytic anemias. A normocytic anemia consists of a low blood cell count, measured by hemoglobin and hematocrit. However, unlike the previous anemias, these next few anemic states are characterized by a small number of normal-sized RBCs, which means an MCV between 80 and 100. This can be caused by a process known as hemolysis. And in this scene, we'll illustrate a few RBC disorders that involve hemolysis by the spleen specifically, an organ that just loves to eat any red blood cell that it deems imperfect. This process is called extravascular hemolysis. Ooh, you see that sky? In case you can't tell, we're smack dab in the middle of Tornado Alley. This region of the U.S., between the Appalachians and Rockies, is where cold air blowing east over the Rockies crosses warm air moving north from the Gulf. This clash of currents leads to twisting systems with a central upward draft, eventually forming storm cells that can rotate at several hundred miles per hour. And while they're known for destruction of homes and crop fields and Bill Paxtons, in this scene, this twister is gobbling up red blood cells like a hungry spleen. Normal red blood cells have a lifespan of 120 days. When they get old and worn out, the spleen absorbs and destroys them. If red blood cells have defects that damage their membranes, however, they wear out and get cleared much more quickly. This process is called extravascular hemolysis because red blood cell destruction occurs in the spleen instead of in the blood vessels. As damaged, deformed RBCs circulate through the spleen, they get trapped in narrow corridors called the cords of Billroth. These cords are kind of like these slats in the fence. While normal RBCs can contort and squeeze through the narrow lining of these hallways, damaged cells can't do so. That's why we've shown the normal-looking tomatoes sneaking through while the malformed ones get caught on the fence. Once the cell gets stuck, it's cleared by splenic macrophages, represented by the macro cage that's gathering debris. These macrophages are a part of the reticuloendothelial system and monitor the blood for damaged or misshapen cells. These macrophages either gobble up whole RBCs or just bite off parts of defective RBC membranes. Because the RBC is contained in the macrophage, and the digestion occurs intracellularly, the hemoglobin inside these RBCs is sequestered and doesn't enter the blood. Therefore, in contrast to intravascular hemolysis, extravascular hemolysis is not associated with hemoglobinemia or hemoglobinuria. See how the hemoglobin hubcap stays sequestered inside the macrocage? That doesn't mean hemoglobin doesn't come back to bite you, though. Recall from our bilirubin billygoat sketch in the GI unit that digested heme in the spleen is converted to unconjugated bilirubin. At Sketchy, conjugated bilirubin is depicted by a billygoat attached with a lesion collar. Unconjugated, then, is an uncollared billygoat, like this one. Getting sucked into the twister. I should also comment on his pee-pee friend there. He represents urobilinogen. Recall from our billygoat farm sketch that more bilirubin in the blood means more excreted in the bile, leading to more converted into urobilinogen in the GI tract. This, in turn, will lead to more urobilinogen reabsorbed from the GI tract, increasing the amount of urobilinogen excreted by the kidneys right into your pee. So expect to see increased urobilinogen in the urine and stool. It just means you have too much bilirubin floating around in circulation, getting excreted. Additionally, when bilirubin reaches the liver, it's conjugated, processed further, and then kicked out into the bile. If the bilirubin gets too saturated, it can precipitate into pigmented gallstones that can lead to biliary colic and cholecystitis. And by now you should know that at Sketchy, when you see the seagull, think seagull. Because the spleen's macrophages are a bit schlappy, some of the lactate dehydrogenase inside opsonized RBCs spills out into the circulation, elevating serum lactate dehydrogenase levels, depicted here by the lactated dehydrated milk filling the air. Probably shouldn't breathe that in. Take shallow breaths, maybe. In the face of accelerated red blood cell destruction, another lab value you should look out for is the reticulocyte count. The reticulocyte count reports how many new immature red blood cells are getting pumped out of the marrow. As the spleen sucks up RBCs like an enraged Kirby, the body attempts to make more. The retic count should increase somewhere above 3%, as evidenced by the plethora of flying teabags. We've chosen a tea bag because reticulocytes are large, round cells that contain a characteristic net-like chromatin, as opposed to mature RBCs which have no nucleus. Hence the net-like tea bags. Plus, a tea bag is kind of like premature tea. Gotta steep it and whatnot. On the peripheral smear, reticulocytes are larger than RBCs, lack that central pallor characteristic of RBCs, and stain a mottled bluish-purple because of all that chromatin. Just remember the shape and color of the tea bags. In chronic extravascular hemolysis, these overworked macrophages are pushed to the limit. As an adaptive measure, they replicate to shoulder the increased workload, creating more red pulp and grossly expanding the spleen in the process. Now, I mentioned earlier that we're going to focus on normocytic anemia for this sketch. So I'd like to introduce you to the normans. Normocytic is defined as a normal mean corpuscular volume somewhere in the range of 80 to 100. Here's the thing to keep in mind, though. Hemolysis is sometimes associated with macrocytosis because of those reticulocytes we talked about earlier, which are larger than mature RBCs. Not only that, the MCV can be low, normal, or high depending on the degree of hemolysis and reticulocytosis. So, while not technically normocytic 100% of the time, at least rest assured that on test day, the following hemolytic syndromes will most likely not produce a substantial change in that MCV value. Alright, now that you know what happens in extravascular hemolysis, let's go over a few of the common conditions that cause it. First up, the most common hemolytic anemia due to red cell membrane defect. Hereditary spherocytosis. Hereditary spherocytosis, HS, is a disorder of the RBC membrane, specifically the proteins that anchor the cell membrane to the inner skeleton of the cell. The prototypical culprit is the protein spectrin, symbolized by these rainbow spectrum bands. These long filaments normally cross-link with themselves to form a frame connecting the external phospholipid bilayer, this TARP in other words, with the internal cytoskeleton. Mutations in the spectrin gene lead to a spectrin deficiency and a weak, inflexible RBC membrane. In addition to spectrin mutations, defects in other structural membrane proteins have been known to result in spherocytosis. These other membrane proteins are integral to the assembly of spectrin. The protein ankyrin, for example, is critical for the correct assembly of the spectrin scaffold. So, by extension, if this ankyrin anchor fails, so does spectrin. 75% of HS is inherited in an autosomal dominant pattern, with the remaining 25% being a more severe form with an autosomal recessive inheritance pattern. We'll focus on the dominant, hence our recurring dominant dominoes incorporated into the mud flaps. As these weak RBC membranes squeeze themselves through the splenic cords of Billroth, little vesicles of membrane pop off. This is sometimes referred to as splenic conditioning. Over time, the cell's membrane gets smaller and smaller, but that smaller membrane still has to stretch out over the same volume of cell. After a few cycles of splenic conditioning, the biconcave RBC disc begins to look more and more, well, spherical. Seriously. Just compare the spherical water tank to the normal biconcave tank to the left. Spherocytes are 2/3 the size of normal RBCs, and because they're no longer biconcave, they lack the characteristic central pallor of normal RBCs. Remember this. They just look like solid round red blobs under the microscope. Of course, there are cells in all phases of the splenic conditioning process. Tiny ones, medium-ish sized ones. Combine that with the fact that your body starts producing larger, immature RBCs to compensate for the anemia that develops, and you're dealing with a wide variety of cell sizes. That's measured on labs as an increased RBC distribution width, abbreviated RDW. As these pieces of cell membrane continue to bud off and the remaining material stretch tighter and tighter over the cell contents, the membrane starts to lose its flexibility. See how metallic and inflexible the side of that tank is? An inflexible cell membrane means an increased chance of it getting stuck in the spleen. Once the RBC gets trapped in the splenic cords, splenic macrophages phagocytose the cell and break down its contents. Because the membrane is weak and overstretched, the cell is also sensitive to changes in volume. This is called osmotic fragility, and it's tested with the acidified glycerol lysis test. In a nutshell, RBCs are placed in more and more dilute solutions, which cause swelling of the cell due to osmosis. While a normal RBC can handle this rather well, spherocytes cannot and will lyse in even moderately dilute solutions. The osmotic fragility test is the classic diagnostic test for HS. A very unique characteristic of hereditary spherocytosis is an increase in the mean corpuscular hemoglobin concentration, or MCHC. Spherocytosis is the only abnormality associated with an elevated MCHC, so remember this one. The MCHC is elevated because the cell size shrinks without a concomitant change in the amount of hemoglobin inside the RBC. Less volume combined with the same amount of hemoglobin equals a higher concentration of hemoglobin in the cell, hence the concentrated stack of hemoglobin hubcaps. Remember all the findings associated with extravascular hemolysis as well. Hereditary spherocytosis causes elevated LDH and increased unconjugated bilirubin levels, leading to jaundice. Up to 50% of infants born with hereditary spherocytosis will develop jaundice. Additionally, about half of adult patients will have gallstones at some point in their lives. Don't forget about those tea bags either, which represent an increased reticulocyte count. A typical finding in hemolytic anemia, but not specific for hemolysis. And the big one to remember? Splenomegaly, represented by that terrifyingly large splenic twister in the back. Splenomegaly is seen more commonly and more prominently with hereditary spherocytosis than any other hemolytic anemia. In up to 75% of cases, in fact. The degree of anemia that results usually only produces mild symptoms, if any at all. Severe symptoms are rare, but the most severe cases are lethal in utero. You may remember from our discussion of hemoglobin Barrett's disease that severe forms of anemia in utero can cause high-output heart failure in the fetus, leading to a generalized and often fatal edema called hydrops fetalis. At Sketchy, it's usually represented by a doused red baby, kinda like this chew toy. Also in patients with severe hemolytic disorders, the short RBC lifespan can lead to aplastic crisis if bone marrow erythropoiesis is suppressed by parvovirus B19 infection. So we've added a plastic toy bone. You know, aplastic. All right. The next disease we'll cover is so similar to hereditary spherocytosis that you should just think of it as a review, with just a few small differences. We've just talked about spectrin mutations causing membrane blebbing and formation of spherical RBCs. Now let's talk about spectrin mutations forming elliptical RBCs, a condition creatively called hereditary ellipsocytosis. In hereditary ellipsocytosis, autosomal dominant mutations in the spectrin gene lead to RBC cytoskeleton defects. So, we've brought back the dysfunctional rainbow spectrum bands, as well as our recurring autosomal dominant domino. Notice, too, the ellipsoid shape of the trailer. The specific mutations in this condition cause the cytoskeleton to lose its elastic recoil. Thus, when the RBC is subject to its usual deformation as it squeezes through the splenic cords of Billroth, its cytoskeleton is unable to rebound back into its normal biconcave disc shape. The cytoskeletal fibers get bunched up, interlock, and the RBC gets pressed into a new permanent elliptical shape. The shape of the cell is the defining characteristic in hereditary ellipsocytosis. So look for those classic elliptocytes on the peripheral smear. Like their spherocytic counterparts, elliptocytes have membrane instability and greater osmotic fragility. Likewise, their inability to contort through the spleen causes them to eventually get stuck there, where they're eaten up by reticuloendothelial macrophages. Hereditary ellipsocytosis is pretty uncommon in the US, but in regions where malaria is endemic, the prevalence of this disease is much higher. This probably has to do with an increased protection against malarial infection, which we illustrate with protective mosquito netting. Like other disorders that result in extravascular hemolysis, treatment for severe hereditary ellipsocytosis includes occasional transfusions as well as splenectomy. Okay, it's time to wrap up with one final disorder, pyruvate kinase deficiency, symbolized by the private property sign. This one's a bit different. Rather than a structural defect of RBCs, this one involves enzyme deficiency. Pyruvate kinase deficiency is an autosomal recessive condition, embodied as usual by our recessive shy kid. The deficient enzyme here is pyruvate kinase, which normally turns phosphoenol pyruvate into pyruvate. This conversion is required for glycolysis, and the RBC is dependent on it for the production of ATP. Deficient pyruvate kinase then means less ATP for the RBC. Think of it as the cell losing its batteries. Most of the ATP produced is used for transport of cations against a concentration gradient in the RBC membrane. Insufficient ATP production and PK deficiency disrupts this gradient, leading to water and potassium loss and defective maintenance of membrane architecture, propagating a kinocyte formation. As a result, the cell membrane becomes stiff as a board. Just as in hereditary spherocytosis and ellipsocytosis, the resulting lack of membrane flexibility prevents the RBC from being able to deform and contort to squeeze through the splenic cords of Billroth, and as a result, they get stuck and phagocytized by macrophages. On peripheral blood smear, these stiff, ATP-less cells form a bumpy outer membrane and are called Burr cells. Just think of this Burr cell bonnet. The spiky points form because the membrane can't recoil after being twisted and stretched as they flow through the narrow blood vessels. While the appearance of Burr cells may help differentiate PK deficiency from some other forms of anemia, they're not very specific and can also be seen in things like uremia and microangiopathic hemolytic anemia. Clinically, patients with PK deficiency classically present with symptoms and signs of hemolytic anemia in the newborn period. Splenomegaly also develops later in life as the macrophages proliferate in order to handle all the extravascular hemolysis going on. Like many other extravascular hemolytic anemias, treatment of PK deficiency consists of RBC transfusions, splenectomy, and potentially bone marrow transplantation, which can be curative. And you know what? I've said splenectomy a lot in this sketch. Because one of the ways to stop extravascular hemolysis is to take out the organ responsible for the whole thing, the spleen. Just cut it out with farming implements. Watch out though, because splenectomy creates a whole nother problem involving susceptibility to infection by encapsulated organisms. Well, I think now's a good time to head to the cellar. I'll wait for this whole thing to blow over. A quick sum up couldn't hurt, I guess. In this sketch, we started with a discussion of how the spleen, and more specifically, splenic macrophages, are responsible for cleaning out the old red blood cells. Well, they also clean out defective ones when the red blood cell membranes are a little suspicious. Hereditary spherocytosis is a mostly autosomal dominant mutation of spectrin, which causes red blood cells to become small, round, and fragile. With their smaller volume, cells become perfectly spherical and lose their central pallor. That loss of volume also leads to the characteristic increased MCHC, a unique feature in anemias. Diagnosis is by dropping a few of these guys into acidified glycerol, where they'll burst. In hereditary ellipsocytosis, another autosomal dominant mutation in spectrin causes decreased membrane elasticity, again causing instability. These guys make little ellipses though, and the whole disorder may be protective against malaria. The only autosomal recessive disorder in this lot is pyruvate kinase deficiency, shown next to that private property sign. No pyruvate kinase means no glycolysis, which is bad for red blood cells, because this can lead to membrane hardening. These crunchy cell exteriors get chewed up by the spleen, and if they make it through, which a lot of them don't, they look like crumpled aluminum cans, giving rise to the characteristic, but not specific, Burr cells on peripheral smear. With all these disorders, expect a normocytic anemia with an appropriate rise in reticulocyte count, greater than 3%, as the bone marrow tries to catch back up. And no hemolysis is complete without discussing labs, which in these cases will include elevated unconjugated bilirubin, lactate dehydrogenase, and urobilinogen in the urine. No hemoglobinemia or hemoglobinuria though, because it's being properly dispatched in macrophages. Worst case scenario, splenectomy to take out the eye of the storm. Oh, and most important thing, very important is to always